So lifestyle medicine is the idea that you take charge. There's elements of critical thinking that we'll talk about. There's the diet aspects, there's physical activity aspects, we're going to talk about some examples in the real world of reversing type 2 diabetes. And the reason we're using this example is it's very, very comprehensive in terms of if you follow what our patient did for her type 2 diabetes, you're also going to substantially impact your risk of pretty much every chronic disease. Because our bodies seem to be designed for a certain way of being managed. Muscle mass, good food, good thoughts. And the things that help one disease process help every other disease process by and large. There's very few exceptions to that. We're going to be talking about waist loss as part of that. We mentioned waist loss, not weight loss. That's an important distinction to have in the back of your mind. We're talking briefly about aging and then how to put all this into action. And in defining lifestyle medicine, it's about our daily choices to prevent or treat disease and to improve quality of life. And you could say daily choices, you could actually say minute-to-minute choices, hourly choices. Because we live in a world where people are going to be really comfortable with giving you excuses for making dumb decisions. They'll tell you all kinds of reasons why you should make dumb decisions. Your parents, your job. As if these things are new. As if people in the past, or healthy people, didn't have problems with their parents or their job or their kids or whatever. Spouses. I've never heard of anybody having a problem with spouses. And we're going to talk, I'm going back to the idea of critical thinking, that the choices you make should be based on evidence and reason, not ideology. Whatever biases you have should be identified. Biases? I drink coffee. I eat meat. I enjoy meat without any sense of guilt at all, and so on. So I have my biases. And you have yours, and there's nothing wrong with them. And if you're going to a healthcare provider, know what their biases are. And if they admit to some biases, that's a really, really good sign. If they claim to be unbiased, they're liars. They're lying to themselves first. We're all biased. But the biases in lifestyle medicine are really important to consider. And lifestyle medicine is the core of conventional medicine. I think it's really important to realize that historically, medicine started with lifestyle medicine. We're going back to Hippocrates and pre-Hippocrates. And often it's seen as in opposition to conventional medicine, when it's actually not. And for example, in my practice and in our foundation, the greatmed.org, which is where our new educational arm, is our biggest supporters are from the conventional medical community. Our biggest supporters by far, such as Kadlec Hospital. And so it's important to realize that this is not in opposition to drugs, surgery, chemotherapy, radiation, blah, blah, blah. It's the foundation of good medicine. Your basic toolkit. And if you use this toolkit wisely, most people can go through an entire lifetime without using a single pharmaceutical agent. Most people. And we'll give you some examples of that. But diet, activity, waste management, sunlight. People who have more sunlight have less disease, which is good to be living in Eastern Washington. Heat, that's the sauna, hot bath concept, and probably cold. For those of you who do those cold plunge things, you're probably right. Even though it seems kind of nutty, but it's got historical precedent. Faith, a huge factor in terms of your health outcomes. Sleep, relationships, purpose we'll talk about briefly. And fun. There's a verse in the Bible that says, except you be as little children, you shall not enter the kingdom of God. And I think that's a fascinating verse. Because as we get older, many of us live in a world where we stop having fun. Where games are not as prominent. Why not? Because you're far better throwing a Frisbee at 70 years old than sitting in front of a TV and claiming that you can't throw a Frisbee, because you can. Lifestyle medicine involves change. If you don't want to have change in your life, you probably need to be in a lecture. There's a horseshoe conference going on right now. There's a triathlon going on right now, an Ironman. You could be part of that. But then you'd probably even have a more desperate expression on your face. Lifestyle medicine, in many times people get caught up in a philosophy around lifestyle medicine. I see this in patients who bring in their nutritional supplements. And they've got some illness, and they come in because they've got heart disease and high cholesterol and high blood pressure, let's say. And they trot out 4 or 5 or 6 bottles of supplements they're taking. And I say, well, are they working? And they look at me blankly like, who would ever ask that? Because if your blood pressure's not coming down, your cholesterol's not coming down, your heart disease isn't going away, why in the world are you taking those supplements? And at this point, this is where I make a lot of people mad, because I say the pharmaceutical industry has a least ethical arm. And the least ethical arm of the pharmaceutical industry is the nutritional supplement industry. It's really important to remember that your nutritional supplements are not natural. And when you wrap your mind around that, it sort of changes how you see what is lifestyle medicine. That's just one example. So focus on cold, hard facts. Is what you're doing improving your health, your well-being, your energy, your sleep, your waistline, your muscle mass? And sort of know why you're doing what you're doing. Let's say you've had a heart attack, and you come to me, and I trot out my program for people with heart attacks. You should be able to see results. You should see your triglycerides come down, your HDL go up, your waistline go down, your energy go up, your need for high blood pressure medicines go down. If you're not getting those results, you're wasting your time and money with me. And remember that your healthcare provider is your consultant, is your employee. That you should treat your healthcare provider with the same attitude as you would treat your plumber or electrician. They should give you results. They're not there to be a god. Although I was taught in medical school that MD meant medical deity, but I found out that was wrong. So have a way of assessing whatever you're doing. And avoid vague terms. So I have people come in and say, what kind of diet do you eat? And our patients, we make them complete a 3-day dietary record before they come in, which is sometimes truthful. And in fact, I had a lady the other day who came in and she was having trouble losing weight. And I said, well, if you started keeping a diet log, we could probably figure out why you're not losing weight, because everybody can lose weight. She said, no, I can't lose weight. I said, everybody can lose weight. We just have to figure out where the calories are coming from and then find out where your barriers are. So how about if you start using a diet log? And she said, she looked at me with a straight face. This is a 70-year-old, really healthy, intelligent lady. She said, but then I would have to write down when I'm cheating. And it was kind of one of those, you couldn't quite believe what you're hearing. But I think a lot of people think that way. They actually live in sort of 2 different worlds. So don't let that happen to you. So vague terms, plant-based. What does plant-based mean? It's a meaningless term used for marketing purposes. So have terms that mean something. We promote an omnivorous diet, meaning eating everything humans have ever eaten, pretty much, when they could get their hands on it. Remembering that humans often starve to death. We don't want, that's not the example we're talking about. And avoid being abolitionist. The world is full of people who will say, you shouldn't eat apples because of such and such. I just had a patient who said, olive oil has phthalates in it. Shouldn't eat olive oil. I said, well, lots of food have phthalates in it. Do people who eat olive oil live longer or less long than people who don't eat olive oil? The answer is they live longer. You'll find very, very many meaningless things thrown up, and you've got to ask yourself, is what I'm being told that lentils have lectins and therefore are bad for me, does that make any sense at all? What happens when people eat lentils should be your question. And be cautious about believing anything, because 90% of what you're being taught most of the time is going to be marketing in some way. And right now, you're being marketed to. I'm marketing to you a method of critical thinking around healthcare that says, what humans have been doing for a long time, thousands of years, works. Just use the parts that work well and discard the parts that don't work. And we're going to talk a little bit about how to avoid the myths and fads. And we're going to be talking quite a bit about the synthetic food industry, because much of what is being marketed as good food is actually just chemical constructs. An example of that would be, start your mind thinking about it, would be protein powders Are those food or are they chemical constructs? And if they're chemical constructs, are they good for you? Where's the evidence for that? So the evidence that we use follows, so we don't do anything unless it has 3 lines of evidence to support it. The 3 lines of evidence typically would be something like historical precedent. Have people been eating lentils for a long time? Eggs, milk, eggs, red meat, fish, lentils again. So have people been eating those foods for a long time? And if they have, they're probably okay. Then what do we learn from high quality medical studies? So if we saw the idea that humans have been eating eggs for a long time to be true, but 8 out of 10 medical studies showed that people who ate eggs died young, then we would say, oh, well, we'll discard the first piece of evidence in favor of the second group of studies. And then the third line of evidence that we often look at is, what do we learn from our patients? What has worked? And so, for example, we promote something called type 2 diabetes reversal instead of treatment. So the idea being that if you've got type 2 diabetes, you should reverse it. And 70 to 100% of the time, you can do that, we would submit. And we can say that because we've never seen a patient who's appropriate body weight, fit, and eats well, who still has type 2 diabetes. And I speak at medical conferences quite a bit. And for when doctors say, well, you can't reverse type 2 diabetes, I say, have you, those 3 criteria for patients, have you ever seen a patient who's thin, fit, and eats well, who still has type 2 diabetes? And they might come up with an exception. The exceptions that we see are people in their 70s, typically tall males, tall, thin males, who have lousy pancreatic function. We can still keep them off drugs, but there are some exceptions to almost everything I'm saying. So we're going to talk about a real-world example of somebody who came to us and said, hey, I just went to my physician. They said I've got type 2 diabetes. And the physician done a good job, worked them up, and she already had signs of kidney damage. So this is a 42-year-old mother of 3. The first crime that the healthcare profession did to her is she had 3 cases, 3 children, and in each of those cases, she had gestational diabetes. She should have been told, ma'am, if you don't take good care of yourself, you're going to have type 2 diabetes. Instead, she wasn't told that. And that we see that quite often. So now she's got an HbA1c in the 10s. She already has signs of kidney damage from her diabetes, which is a bad sign for just about everything. When you have signs of kidney damage and diabetes, you've got your risk of stroke is way up, your risk of heart attacks go way up, and of course things like dialysis and losing vision because of the damage that diabetes does to the eyes. And these are all real-world things that we see every day. None of the things I'm talking about are exceptional. What's exceptional is this 42-year-old said, instead of just going on these drugs I'm being offered, there might be something better. In other words, she started with an attitude that says, what can I do about this problem? In addition to her diabetes, she had significant weight problems, high blood pressure. She was on a huge dose of metoprolol, the maximum dose of metoprolol to control her heart rate. And she'd had several workups for her rapid heart rate, which had found no cause. And we see this quite often. But the trouble is the metoprolol, which controls the heart rate, also makes you fatigued and depressed. And she's fatigued and depressed, as a matter of fact. So she comes in, she's 196 pounds, she's about 5'4". HbA1c of 10.7%. Anything over 6.5% is highly abnormal, true diabetes. Anything over 5.7% is high risk. So in our practice, 10.7% is really high. And as I said, she had kidney damage already, and that's a really bad sign. She's on these drugs. She's really got terrible cholesterol. She's on a bunch of antidepressants as well. She doesn't feel good. Did I mention she has 3 young kids as well? How's that for a package? So 4 months later, she has completely reversed her diabetes. And in follow-up 2, 3, I think we're at 4 years with her, for example. Her weight's gone down 40 or 50 pounds and stayed down. She's remained ex-diabetic and she is on a small dose of antidepressant that she doesn't want to give up on, and otherwise she's off of all of her drugs, energy better. And right now she's in Switzerland at a martial arts. I can't pronounce the form martial arts she does. It's a Korean name, but she's in Switzerland right now at a martial arts conference.
But still, it has me in that mindset of still wanting to eat,
So we'll talk about that when we come to, yeah, so the basic answer is celery. And I apologize for sometimes I'm going to say things that sound like really grandmother kind of stuff, and I apologize for how that will sound, but it's the reality. Because just as gentleman, it sounds like is dealing with steroid-induced type 2 diabetes, and it's a particularly tough issue to be in, and a lot of people with autoimmune disease are in that situation. So part of what we do, and this is a bit of a niche question, an important one though, and part of what we do is we improve the effect of the immune system, the effectiveness of the immune system, so that their autoimmune disease is less prevalent. They don't need as much steroid. And we actually have a podcast on our use of this approach with autoimmune disease that would be helpful in that context too. So your question is a really important one, a really complex one. And then I said something glib like celery, which is partly true. So we could actually maybe have a few words at the end, and we could point you to the podcast, because of the autoimmune podcast I think would help. What's really important is that no combination of medications could have done what she did.
I'm very surprised to see that her thyroid was changed by her diet and exercise.
You're reading ahead. Yeah, we often see people's thyroid doses go down or eliminated when they lose weight and improve their immune system. We don't really know why, but it's just an observation. I've never seen any data on it, but it's a frequent observation. So she has, as far as we know, she's eliminated her risk of future diabetic complications. Nobody's actually done a study to prove what I just said, but we're pretty sure that's the case because we've never seen an exception to it. In particular, it's the issue of dialysis for her. She's dramatically reduced the medications that were sucking the energy out of her. She's improved her ability to take care of her family, including that ripple effect. If a parent is taking better care of themselves, the kids are going to learn to take better care of themselves. It's going to create a different culture, which we think is an important part of this. She doesn't have to take blood sugars. She doesn't have to visit doctors very often. We almost never see her now. And she's dramatically reduced her healthcare costs by a factor of thousands of dollars a month, typically. So somebody this age would almost certainly be on long-acting insulins pretty soon. Most practices probably would have started her on a long-acting insulin at the time. Those things can cost easily $1,000 a month. I've got patients who are taking $20,000 to $30,000 a year of medicines for their diabetes. And take the Ozempic, $1,000 a month, something like that. And she didn't have to do any of that. So in other words, what we've done is relieved her of a huge financial burden, or her insurer of a huge financial burden, herself of a huge time burden, and then the toxicity of drugs. Remember that all medications, and I'm a conventional physician. I prescribe drugs all day, every day. But every time I do, I like to remind patients that these are poisons with potentially useful side effects. And the useful side effect I'm hoping for you, you pretend you're the patient in front of me, for you right now is blah, blah, blah. But if you can get off of it by doing X, then you should, because this is a poison with potentially useful side effects. And this is kind of a way to look at the world of medicine, that things like having too much weight around your waist, eating too much dietary sugars and starches, and we could put processed foods in there, not being active enough, having insulin resistance, all of those kinds of factors address almost every chronic disease that we've got. Autoimmune disease, heart disease, stroke, cancers. Not every, but almost every. And when we look at people who make a broad range of good choices, so this is from the Nurses' Health Study, and health professionals follow-up study. So somewhere in the region, 130,000 people followed for between 20 and 30 years, depending on which cohort is in here. Then those that had what's vaguely defined as a good diet quality, which is an omnivorous diet, meaning they eat some of everything, but with more fruits, vegetables, beans, and grains than average, who aren't too chubby, they've got a body mass index less than 25, which means they have a waist that goes in, not out. 30 minutes or more of physical activity every day. So where did this idea of 20 minutes 3 times a week come from? I don't know if any of you have been told, oh, get 20 minutes 3 times a week. That's not just dumb, it's immoral. You probably need a lot more than that. 20 minutes 3 times a week is better than nothing, don't get me wrong. I'd prefer 20 minutes 3 times a week over nothing. But you'll notice these people did 30 minutes or more of moderate to vigorous activity. They drank a small amount of alcohol. The ones that didn't drink didn't do as well. The ones that drank too much didn't show up for the study. And they didn't smoke. Those 5 factors associated with 80 to 90% less heart disease and stroke, about 60% less cancers, about 90% less type 2 diabetes. And those are things that every single person in this audience can do. And there's not a single health guru with their books and their fancy ideas and their supplements that can give you results, anything approaching this. So you can choose a better health trajectory. And in your mind, if you sort of see this as binary, it's not really binary, but it's helpful to think of it in a black and white way. In reality, many people who choose this primarily lifestyle approach to medicine still use, in other words, depending on their individual choices for their healthcare, still need to use medications sometimes. Remember, I write medications all day, every day. And for example, the gentleman with the lung disease that we just talked about, this is way too black and white for his actual case, but it's a good way to think about it. So you can choose. Let's say you go to a doctor and you've got high blood pressure. You can choose to educate yourself about what causes high blood pressure and not take medications and instead get more exercise, lose weight, eat better, more celery. Did I mention celery? Or you can say, you know what? My doctor cares about me and he's putting me on these high blood pressure drugs and that's what must be what I need to do. And the trouble is your doctor doesn't actually believe you'll do the other stuff. So doctors are heavily supportive of lifestyle medicine. But probably the single most common comment I get when I speak at medical conferences, how do you get patients to do this stuff? In other words, doctors give up. They're tired of telling people to do things that they won't do. So your choices, and then the bottom line is get yourself educated, do what you can do, and you probably won't need the drugs, and you'll have a better health outcome. Or just go along with it, be a pawn of the pharmaceutical industry. How's that for a nasty comment? And take more drugs and more drugs and more drugs. And then you can take some drugs for the side effects of those drugs, and so on. And we don't think that's very smart. And most doctors don't think that's very smart either. In fact, most doctors take far better care of themselves than they tell their patients to because they're burned out. And I don't think I'm exaggerating when I say that. Ask your primary care physician, hey, how much time do you spend educating your patients on lifestyle? And why don't you spend more time? And you're going to get a couple of answers. One is I don't have the time because I have to see 4 patients an hour. And the second is patients won't do it. So there are exceptions. Take the high blood pressure medicine example. So I have a nurse who comes in, and she's got a blood pressure of 220 over 100. And she's a nationally ranked taekwondo person. She looks like $1 million. So she's thin, fit, eats beautifully, and she still has a high blood pressure, 220 over 100. It wasn't her lack of celery that was causing her high blood pressure. She had an adrenal tumor. So remember everything I'm saying. Whenever I say something that sounds too simplistic, remember there's examples that are an exception to what I'm saying. So we're going to talk about the Mediterranean diet. So Mediterranean diet currently is not a religion. It's simply the dietary pattern that has the most evidence for improving health care. And so this dates back to the 1950s when a guy called Ansel Keys from Iowa did a study called the 7 Countries Trial, and he ran around the world. It must have been fabulous to be just able to just tour Europe and the Far East and stuff on somebody else's dime. And he just analyzed what people ate. They did things like taking plates of food off people's tables and putting them in a blender and figure out what was in the food and things like that. It was really a fascinating study, 7 countries trial. And that study ended up showing that it looked like the Mediterranean diet pattern had the best health outcomes. And that was a reasonable philosophy, and Greeks seemed pretty happy, so that seemed okay. And then they did a randomized control trial of taking the American Heart Association style approach compared to a Mediterranean style approach and to people who had just had a heart attack. It was called the Lyon Heart Trial. At the end of 4 years, the people on the Mediterranean diet compared to the other prudent diets. So these were 2 prudent diets compared to each other. This was not Joe Sixpack and a McDonald's compared to a good diet. This was 2 good diets compared to each other. So, besides, I'm not sure they had McDonald's in France at that time, or six-packs. So they had, at the end of 4 years, the people on the Mediterranean-style diet had a 70% less risk of having another heart attack or stroke, over 50% reduction in death, about a 60% reduction in all cancers. And there's no difference in medications, there's no difference in smoking rates, there's no difference in activity, there's no difference in weight. In fact, there's nothing they could measure that explained the difference in outcomes, a huge difference in outcomes. Not in cholesterol, there's nothing. And so this is a really important factor, is that the benefits of good diet and exercise involve variables in your body that we don't know how to measure. And so this is super important when you're looking at somebody who says, well, you shouldn't eat this because we measured this and we found this. Well, this, and this have to be defined as being important, because among the best studies ever, people haven't been able to find out why they worked. And this data has been reproduced over and over and over again. So overall, we have good studies. In our book, we go into great detail about these studies. But for Mediterranean diet and cognitive dysfunction, heart disease and stroke, type 2 diabetes, we'll touch on that a little bit. Cancer, especially breast cancer. There is evidence to show that less environmental impact of the Mediterranean diet and substantial effects on mood disorders. So I should have added autoimmune disease to this for the gentleman in the back as well. And if you look at this, so this is a meta-analysis. So the meta-analysis is a statistical tool you use to combine lots of data from different studies. And so they looked at prospective cohort studies, so where they took groups of people and studied them prospectively. In other words, you say, hey, we're going to take this group of people, see what they're doing in terms of activity or diet or whatever you're measuring, and we're going to follow them for 4, 5, 10 years and see who has a better health outcome and why. And so if you look at this study, so they went for this group, they had about 4 million people. The studies ranged from 5 to 16 years. And they defined the perfect Mediterranean diet as being high in vegetables, fruits, grains, legumes, fish, and olive oil, 1 to 2 servings of alcohol per day, and you don't take the alcohol away from those Greeks, and up to 3 ounces of meat per day and up to 5 ounces of dairy per day. In other words, this was omnivorous diet. There's nothing extraordinary about this dietary approach. And and then there's a scale they use. In this particular case, it's an 18-point scale. For every 2 points of greater adherence to this dietary approach, you had substantial reductions in total mortality, cardiovascular disease, and cancer. And so if I was sort of to define what I'm talking, so the Mediterranean diet, because of its loosey-goosey nature, fruits, vegetables, beans, grains, all traditional foods pretty much, olive oil, then I've tried to put a little bit of substance behind our recommendations, because we think that what it doesn't take into account, partly because of where it was studied, where people eat their own food made at home, which is a distinctive part of the Mediterranean diet studies, is that they were actually advised how to cook at home. And that's part of what is often lost in the interpretation of them. So we argue that it involves a lot of fruits and vegetables, and if you think of having a fruit or vegetable with every meal and snack, you're going to be way ahead. If you just sort of think of that as a rule that you live by. So like, you might be somebody who brushes their teeth twice a day, whether you need to or not. And having that kind of, you wouldn't dream of not doing that. Then having that same idea for fruits and vegetables with every meal and snack is a huge step ahead. Plenty of beans and legumes, raw nuts and seeds, intact or minimally processed whole grains. So we give all of our patients actually a sample of true whole grains, groats, oats, rye, barley. to show how they can eat these grains without using flour and cook them at home, and how to eat them and enjoy them. And it's also dirt cheap. That's a great thing about this approach. Well, one of the big problems with this approach is nobody's figured out how to make a lot of money on it. Using extra virgin olive oil, we'll look at some evidence for that. Eating good fat with every meal and snack. So good fat really alters how your body processes carbohydrate. And so that's why this is not a low-fat idea, which also makes food taste better. And one of the things about the Mediterranean diet studies is that they have higher adherence rates. In other words, the people in the diets, on the Mediterranean diet arm of the studies, tend to drop out less because they're enjoying their food. And that's often used as a criticism. And I say, well, why would you criticize an approach that people enjoy more? Are you just against people enjoying themselves? And that's the impression I actually get in a lot of lifestyle medicines. They don't want you to enjoy them yourself. Fish, but also all the other animal proteins, including dairy. Dairy probably should be primarily in the form of cultured dairy, yogurt, kefir, cheese, rather than milk. Milk actually doesn't have much of a history of health as a health food, and includes moderate alcohol, and we'll talk about that again in a moment. And it's not low fat, it's not low in saturated fat, it's not low in cholesterol. So no other dietary model has the kind of health benefits that we're talking about. Not vegetarian, not vegan, not keto, not paleo. And so we're all for saying, hey, let's look and see if we can improve on the Mediterranean diet or if there's a better approach. Nothing wrong with that at all. But let's not ignore what we already know. And what we already know is that omnivorous whole food diet appears to be associated with best health outcomes. And we call that a Mediterranean diet. So one of the things about the Mediterranean diet studies is they all feature extra virgin olive oil. And typically, like in the PrettyMed study, they gave people a liter of olive oil a week to use. If the people actually used it all as an individual basis, that'd be 1,200 calories a day just in olive oil. So we think that they must have shared it. Because olive oil has gotten pretty tubby. But olive oil is associated with better brain health in various ways of measuring, less cancers, less heart disease, and less total mortality, and in a dose-related fashion. I didn't mention dose-related fashion earlier, but when you look at a study involving lifestyle change, look for a dose relationship. In other words, if you get more exercise, do you do better? If you do a little bit more than that, do you do better? Because when you see a dose relationship, in other words, a little bit's good, a little bit more is better, a little bit more is better still, then it really lends credibility to the probability that it's a true effect.
Oh, I see now.
Yeah.
But eating like tuna all the time because you hear of mercury and stuff, so I try to only have that like once a week, but is that something you think, like can't even like sardines and herring and stuff?
Yeah, we can't, so we would argue, so the question is there a problem with eating tuna a lot? We have not been able to find any evidence in adults, for any fish that had, even the ones with mercury, as being associated with poorer health outcomes. And believe it or not, this has been studied. That's a separate talk. But it appears to be that the body of the human adult can handle it just fine. So we don't have any problem with that. And incidentally, with anything that we're saying that you find out later on that we might be wrong about, shoot us an email, because we love to find out if we're wrong, because we don't want to keep being wrong. But we've looked at this extensively. A little while back, I was giving a talk on this. I was part of a talk introducing a new salmon cookbook that somebody had written, and so I was part of that, talking about the benefits of fish and health. And I was in front of a Portland audience that these were all tattooed, Birkenstocked, and pierced. And I thought, this crowd is going to be really anti-mercury. And I presented the mercury data in fish and said, eat all the salmon you want. And tuna for that matter, and they were very acceptable with it. So I was expecting to start a riot, and I didn't. So I won't dwell on these two slides except to give you a pop quiz later. But these are called forest plots, and this is an example of where you look for multiple studies showing a benefit. So, for example, if I gave you one study that said, "Wow, olive oil is really good for you," and didn't comment on all the other studies. So when anybody ever, including me, ever says, hey, this study shows that X is really good for you, then the first question you should ask that person is, are there studies showing that X is not good for you? In other words, what is the opposing data? There's many critical thinking questions you've got to ask in healthcare, but that's one of them. So what we see here is that dozens of studies on olive oil have shown reductions in cancer rates and reduction in total mortality, meaning over the course of the study, fewer people died if they were eating more olive oil. And typically this is measured as a dose response curve based on 7 grams of olive oil per serving per day. So the higher number of servings, the greater the degree of benefit. But we're seeing a very, very consistent outcomes for olive oil, and it appears to be quite real. If you're choosing olive oil, choose extra virgin. It's going to cost you more money. Like in our, right now I'm living in a household of 5, because it's sort of a blended family kind of situation. I'm still happily married, but we're living with friends because of some other problems. And so for the 5 of us, then we go through about half a gallon of olive oil a month. Now that's not, for good quality olive oil, that's not an insignificant amount of money. You have to save the money somewhere else. But we can save that money by going out to eat less, for example. How about that for a concept? So don't complain about the cost of extra virgin olive oil. Take it out of your vitamin budget if you're taking nutritional supplements. And then the lady asked about, what about avocado oil? All the other commonly used vegetable oils are highly processed, nutritionally depleted, and let me guess, your avocado oil on the front says cold pressed. It probably does. They almost all do. Avocado oil, grapeseed oil, canola oil, safflower oil, soy oil, peanut oil, you name it. Pick any oil you want and plug it in here, any of the oil that you'd find in a supermarket. And I'll mention some exceptions in a second. All of those oils are industrial products, typically processed at between 250 degrees Fahrenheit and 500 degrees Fahrenheit. They are highly filtered to get rid of anything that might have any flavor in them, because these things don't taste good. So you have to ask yourself, why is avocado oil something that our California relatives weren't eating 40 years ago? Well, it's because they hadn't figured out how to make it taste decent by industrial processing. The same to canola oil. Canola seed is a rapeseed. It was primarily an animal feed product because it's toxic to humans. Then the Canadian Oil Licensing Authority, canola, figured out how to make it, so they did a genetic modification in the 60s so that they could, because in Canada you can grow vast quantities of this on the prairies, and they figured out, but the stuff tastes like turnips, right? The oil, when you squeeze it out of the seed, it tastes like turnips, and people didn't like that. But you process it enough, strip all the flavor and nutrients out of it, and you get canola oil, and then people thought that was great. Well, where are the health outcomes that says avocado oil, grapeseed oil, canola oil, any of these are good for you? And as far as I know, there are none. In fact, in the slide there, if you want to look at it later, the only studies that we know of for these, what we call semi-synthetic oils, are the Minnesota Heart Trial and the Sydney Heart Trial. And so in both these studies, the people on the safflower oil arm of the study actually had a higher death rate. And it's actually worth reading these papers, because these were originally published as positive studies because their cholesterol levels were lower. The fact they had a higher death rate was sort of glossed over. And we see this in medical studies all the time, where the really important finding, there's a drug called gemfibrozil, which is still being used for triglycerides. And you look at the data and you're thinking, how would a doctor who actually knew the studies prescribe this stuff? And how would the FDA approve of this? And it just tells you that it's really weird. The common sense does not seem to apply to a lot of these medical studies. So if it's a highly processed vegetable oil, we say skip it. And the only one we know of you can rely on is extra virgin olive oil.
Okay, 2 more things. Coconut oil, and then
Coconut oil is probably okay. No data.
the pan sprays, olive oil, are those still okay?
Maybe. So the question is, are the pan sprays okay? And the answer is nobody really knows. Nobody's ever done a study on that. We tend to just use olive oil and butter. But occasionally my wife uses a pan spray. but we don't tend to use it much because it looks suspicious to us. But we aren't really abolitionists. Coconut oil has been used for thousands of years in human nutrition. There's no decent studies, but it's probably okay. It's simply based on the historical precedent argument. It's not a real super strong argument, but it's not an unreasonable one. We've got a few questions we're going to take in rapid succession.
Yeah, I want to go back a little bit to the vegetables. We're talking about vegetables, and it's kind of the same concept as the oils. So you know that a lot of people or whatever, in the groceries, there's a organic section, and there's the regular section. So what do you prefer? I mean, is it...
I buy whatever looks the best. So the question is organically grown vegetables better than non-organically grown vegetables? And we have 50 years of data that says it doesn't seem to make any difference. And so for me, whatever looks the best is the one to get. And obviously the price might sway you as well. The whole issue of organically grown is really a tough one to define because which chemicals are they using? It's not that the organically grown ones aren't using chemicals, it's that they might be using different chemicals. And so it's really a tough area to nail down. But in the time that we've been using these different chemicals to grow crops, humans have been living longer and better than they ever have in recorded history. So it's hard for me to see that that is a highly toxic effect in the absence of other evidence. And then Shelley, after that, there's a lady there who's if we don't do something, she might just come up and clobber me.
You mentioned using olive oil and butter.
We're fans of butter. And sometimes when you're cooking, then the olive oil butter combination gives you better release. When I cook my eggs in the morning, I just use olive oil. But if you ever want to have, if you want something that might be better in the type of pan you're using, a little bit of butter and olive oil together, it's also great for flavor, in my opinion.
I've tried extra virgin olive oil. I was not a fan. Is the non-extra virgin olive oil that doesn't taste okay for you?
So the question is there a health benefit to the EVOO, the extra virgin olive oil? And the answer is most of the studies seem to hint that there is, and the basic biochemistry suggests that there should be a benefit to the extra virgin olive oil over the more, let's define olive oil for a second. So the extra virgin olive oil is the first pressing of the olives. You take your olives, and you can, in Portland, you can go down to the Durant mill and watch this happening. Put them into a press the oil out of the olives, out comes the olive oil, and that's exactly the same olive oil that humans have been having for the entire recorded history of mankind. And it's loaded with different chemicals that appear to have health properties. Then you've got this mash of squeezed olives behind. And those are processed in different ways to extract the last few drops of olive oil, including in the last stage, they put in a solvent to extract the last of the olive oil. And then they boil that solvent off. So the question is, the data we have suggests that the extra virgin olive oil has unique properties that are beneficial. The background to this question is some people simply don't like the flavor of extra virgin olive oil. And so we think that the other forms of olive oil are probably still beneficial over other vegetable oils. So it's better to use a non-virgin olive oil over a grapeseed or avocado, probably. There's some chemical reasons why that might be the case. The other thing is to sort of mix some extra virgin olive oil and some non-virgin olive oil and try to find flavor combinations that you like. But I would still favor any olive oil over any other vegetable oil. How's that for an answer? Did I do okay? Okay, so other whole food. So we talked about olive oil, we talked about other vegetable oils. Other whole food Mediterranean diet concepts we use are as much variety as possible. I mentioned vegetables are in whole fruit with every meal and snack. Whole grains or beans and lentils every day. Probiotic foods on a daily basis. So that'd be things like fresh sauerkraut, yogurt, kefir, kimchi, if you're so inclined. Good fats, extra virgin oil we've talked about, raw nuts, dairy, eggs, meat, small amounts of alcohol, almost all foods prepared at home, and we'll talk more about that in a second, and avoiding sweets, sweet drinks, and that includes juices, and really, especially if you need to lose weight, watch out for foods made with flour. And if you're hardcore and you really like bread, get your own flour mill. It's really worthwhile, and it will actually pay for itself. I promise, cross my heart. Avoiding fake or highly processed foods. So fake foods, we're going to spend a few slides on this and just the degree of evidence that these cause problems. So some of them that are obvious. So we talked about highly processed vegetable oils, and watch out for altered oils too, the hydrogenated oils. But then think about egg substitutes, milk substitutes, butter substitutes. Where in the world is this idea that the substitutes, the fake foods, are any better than the real thing? And I asked this of the dietitians in the hospital, you offer egg beaters. People feel that that's healthier than real eggs. What is the basis for that? In other words, we should have reasoning behind every of these things, and anybody who's promoting an idea should be able to defend their idea. And you should be able to ask them, because remember, you're the customer. The healthcare professions are your servants. Yes, ma'am.
So what about people who are lactose intolerant?
Don't eat milk.
Milk that can't have cream, butter, so.
Well, you don't have milk or cream. I apologize for that. Seems like too simplistic an answer. But there's people who can't have strawberries, people who can't have milk, and there's people who can't have wheat. You just find other foods that you can eat.
But what about the milk that says it doesn't have lactose, it's lactate?
If lactate works for you, that's great. Yeah, so if lactate works, so lactate is so there's a number of reasons why somebody might be intolerant to milk. It can be proteins, it can be sugars. And so if lactate, which breaks down some of the sugars, works for you, that's a great alternative. But you can have a dairy-free diet and be perfectly healthy. Was that a satisfactory answer, ma'am, or did you want something better? Okay. So commercially processed foods. So these are foods processed outside the home. Industrial process, sometimes when we're being mean, we call them chemical constructs. And there's a ton of studies on this, and it shows that on a dose relationship basis, people who eat more of these foods have higher rates of total mortality, higher rates of cancer, especially breast cancer, and higher rates of heart disease, stroke. And these are published in the major medical journals. None of this is fringe data. Studies from different parts of the world, including different baskets of products. And it's very consistent data. I'm not aware of any data to the contrary that says, wow, if you eat more highly processed foods, you do better. Depression and anxiety. How often does a person go to a psychiatrist and before being put on an antidepressant says, what are you eating? Because if you're eating more processed foods, that actually may be the reason you have depression. And the data is actually quite sound for that. And yet it's not what we see being done in the real world. And why not? And so what you've got to ask yourself is, where can I take control with whatever my health problem is? And one of the areas you can take control right now is if something is manufactured outside your home, think twice about using it. Think of using it as a special occasion food. On my birthday, I get Cheerios. I actually had Cheerios this morning because I had breakfast at the hotel and they had Cheerios. But it's a treat. It's not something we would have in our home because it's not good food. My son pointed out that we didn't have dessert last night, so maybe we could have a treat this morning. And the issues around sugars. So we talked about highly processed foods in general. The issue around sugar is and refined grain. So if I give you a slice of whole wheat bread, it has about as much effect on your blood sugar as if I gave you the same number of calories of straight sugar. So these highly processed, refined carbohydrates, whether they're a true sugar or just a flour product, have pretty consistent evidence for harm, for almost all harms, including brain health. And so just watch out for all of the refined carbohydrates, which are really a dominant part of the food supply that we're talking about when we're talking about processed foods.
I have a question about that bread you said.
We might have to cut you off. Yeah.
I'll be quick. If you add fat, like peanut butter or something on the bread, does that change the effect of the blood sugar?
Yes. So I bet you that was a softball question. She knows exactly what the answer is. And it's a, but it's a good, no, it's a good question. And if any of you have softball questions that say, hey, everybody needs some exploration of this idea, then exactly like she just did, that's actually a good thing to do. So what she's pointing out is if you include a fat with a carbohydrate, so peanut butter on a slice of bread, your blood sugar and blood insulin levels are dramatically improved. And so that's why sandwiches work, for example. And we can name any number of examples. If you have a handful of raw nuts with a banana, your blood sugar rise will be a little lower, and so on. So the concept is an important one. Another one is if you are going to eat a bunch of carbohydrates, go for a fast walk or skip rope or something. That'll help too. In our book, we tell you how to make your own nut butter, which is the preferable option. Slightly below that is if you go to a store where you can grind your own nut butter. But the worst case is if you don't read the label and you buy something that's not butter, not nut butter, but actually a sugar substitute combined with some ground up nuts, such as Jif and so on. I probably shouldn't use brands, should I, Shelley? One of these days I'm going to get sued. So in light of all this, we really think that one of the best things we can do for people is to have them concentrate on cooking whole foods at home. You'll save money, you'll save health, and you'll be a better influence on your family and friends. So instead of going out with friends to eat, why not say, hey, we're all going to go home and we're going to go to our place and we're going to put together a meal. Somebody's going to chop vegetables, somebody's going to saute something, blah, blah, blah. So we're going to go into a little bit more detail on reversing type 2 diabetes. And once again, the reason that we're emphasizing type 2 diabetes is, that was sort of what part of our brief that we were given by when we were talking about giving the talk. Secondly, type 2 diabetes covers such a broad spectrum of disease that if you behave as if you're type 2 diabetic, you're going to pretty much take care of almost all chronic disease. So it's the essentials for our approach to autoimmune disease, for weight loss, for cancer survivorship, for reducing heart disease and stroke, blah, blah, blah. And if you just look at the population in the United States that have what we call metabolic syndrome, insulin resistance, that kind of thing, it's probably about 50 or 60% of Americans. And so when we look at the type 2 diabetes issue, which is the same as the metabolic syndrome issue, then it gives you an understanding of why we emphasize this so much. Behave as if you're a type 2 diabetic, and you're going to relieve yourself of a whole lot of problems, even if you don't have type 2 diabetes. So the spectrum of insulin resistance. But you think of type 2 diabetes as being part of a spectrum, and the earlier you catch yourself on this spectrum, the better your health is going to be, because that's when to reverse it. And we'll talk about more of that in a second. But think of the type 2 diabetes as the endpoint of a spectrum of disease. Is my red thing showing up here? Not really. Type 2 diabetes is the endpoint of a spectrum of disease that started when some doctor said, you know what, your blood sugar goes up a bit. And you looked and you said, wow, I'm carrying a little bit too much around my middle. And maybe I have high blood pressure. So, and a common example we use when we're speaking to physician audiences is you're looking at a 35-year-old guy who's a little tubby and he's got high blood pressure. What are you going to do? Are you going to do the dumb and easy thing and put him on a blood pressure medicine? Or are you going to tell him, you need to lose 15 pounds? Which one's good medicine? There's only one of those two answers that's good medicine. And there's sort of this moral imperative behind what we're talking about. And we live in a world that's lost a lot of sense of moral imperatives, I would submit. And the medical community certainly has. And part of the reason we have is it's really hard work. And it's really hard to do it when people don't really want to hear it. People don't really want to hear, look, the best solution for your problem is lose 20 pounds. And a lot of the time, that's the right answer. So see type 2 diabetes as the end of a spectrum, which should have been caught before.
What if I crave a lot of sugar? I know I eat way too much sugar. My blood tests all come back just fine for sugar and diabetes.
So the question is, is excess sugar a problem in and of itself in the absence of diabetes? And the answer appears to be yes, but the evidence is not as strong. So we would argue that excess sugar in and of itself is associated with more cancers, more heart disease, and more dementia. But none of that evidence is anywhere near as strong as it is in people who have pancreases that aren't as good as yours. So this gentleman, for example, you can go up and shake his hand later, has a fantastic pancreas. He's got adequate muscle mass in relation to the rest of how his metabolism works. And so he's getting away with it in terms of biochemical measurements. Is he getting away with it in terms of long term? And we don't know the answer to that. I wouldn't take the risk, but you might get away with it. I have an 86-year-old father-in-law who heats with wood. We just went and helped him stack. This is gigantic. It was 4 truckloads of wood, 5, I guess. Anyway, a whole bunch of wood stacked for him that he had split. He kind of lives on carbohydrates. He's 86 years old, sharp as a tack. You know, not everybody falls into our expectations, and he's gotten away with it. He went to the dentist for the first time in 30 years. This guy, did I mention he lives on carbohydrates? Goes to the dentist the first time in 30 years, no problems. So, you know, some people are blessed. Maybe you're the one of the blessed ones. So what are the causes? Being sedentary, waistline, all the things we've already talked about. Too much refined carbohydrates, low in fibers, including whole grains. Certain micronutrients are involved. And we don't really know how all that fits in. Vitamin D is an example. Magnesium and so on. Alcohol is actually protective. A lot of medications, as the gentleman pointed out, if you take certain medications that we give you, you get diabetes. And choosing your parents poorly is always a bad decision because there's a strong genetic component.
So I've seen potatoes mentioned on there a couple times. What's the deal with potatoes? Like potatoes.
So potatoes and corn are both really high starch loads that we see in practice as being really interfering with people's ability to lose weight and get their blood sugars under control. Now, if you're a Irish bricklayer burning 6,000 calories a day, you can eat all the potatoes you want. So potatoes in and of themselves are good food. If you've got a waistline problem or a blood sugar problem, watch out. How's that for an answer? Okay. So what are the risks? Why do we care about type 2 diabetes and insulin resistance? We care about it because it damages every cell in your body. So higher total mortality, stroke, heart attack, more joint disease. So for example, if you've got type 2 diabetes compared to somebody of the same weight and exercise level who doesn't have type 2 diabetes, you're more likely to need a hip or a knee replacement. There you get more joint breakdown. We don't really know why, as far as I know. You're more likely to be depressed, kidney failure, and dialysis. Going blind. So it's one of the things that we deal with quite often is patients in their 80s, sometimes in their 70s, who have lost a substantial amount of their vision from macular degeneration associated with their metabolic syndrome or type 2 diabetes. Because the macular degeneration occurs before the diabetes. So you don't have to have diabetes before you get the diabetes-related effects. In fact, in some populations, as soon as you tip over at all into insulin resistance with HbA1cs, which is one of the measures we use, in the high 5s, your risk of stroke and vision loss already has dramatically raised, and your doctor doesn't even have numbers in front of you, in front of him or her, that would tell you that you've got a problem. So actually, that's another idea for you, sir, is you look at your blood sugars and say, is my HbA1c 5.7% or below? And that would be another way of sort of assessing your sugar intake. But you might just be fortunate. It's just possible. The same things that are associated with diabetes are also associated with depression. So if you got depression, treat yourself as if you had diabetes and see what happens. And when we look at the kind of lifestyle approaches that reverse type 2 diabetes and we apply them to people who have cancer, we have an improvement in outcomes, meaning survival, reduction in recurrence rates, and reduction in side effects of conventional cancer therapy that rivals that of chemotherapy and radiation. And when I say that, I'm not saying you don't get chemotherapy and radiation. We do it all. We hit our patients with everything we got. But when you realize that the lifestyle component is as important as what is sort of seen as the more mainstream or conventional approaches, you say, wow, I've got to take more charge. I've got to be more in charge of my health and not just leave this to my oncologist or heart disease doctor or endocrinologist, because I can do a whole lot more, and what I can do in many cases is more important than what my doctor is going to be able to do for me. And this is, looks at the metabolic syndrome. So metabolic syndrome is waistline, triglycerides, HDL, blood sugar, and blood pressure. So if you've got 2 or 3 of those factors, you have the metabolic syndrome. And you can see the more of these factors you get. So the vertical axis is heart disease and stroke. The vertical axis is heart disease and stroke, and the horizontal axis is the number of factors that you have of those that I've mentioned. So waistline, blood sugar, blood pressure, triglycerides, and something else. What have I missed out? Blood pressure, maybe? Anyway, those 5 factors. And you can see that as soon as you hit 3 of those 5 risk factors, your risk for a heart attack or stroke is already doubled. Is that what you want? Do you want to wait until you have type 2 diabetes, is my point? Or do you want to say, as soon as I have anything going wrong, blood pressure, doctor telling me my blood sugar is a little bit too high, telling me I need to lose a few pounds, why not take aggressive action then and make it so that your later years are far better?
I see CRP, but I don't know what it is.
C-reactive protein. This is actually a slide showing it's a useless number. CRP is HSCRP is a number that's used to measure inflammation in the body, and it's used as a cardiac risk factor. In reality, in the real world, in a population, it's actually a very useful number. In the real world, on an individual basis, it's useful as waste of $25. But it's a HSCRP, C-reactive protein. It's just a lab test. So when do you take action? You take action at the first sign that you've got a problem. And for most people, that's when their waistline is bigger than it should be. And the sooner you take action, the easier it is to reverse. So for example, our example, Stephanie, who had type 2 diabetes at 42 years old and kidney injury, and she reversed all of it and stays reversed. I think we're at 4 years now with her. By addressing it when she did, she had plenty of pancreatic reserve and she was able to do it. If she'd waited another 20 years, after 15 years of insulin use, for example, she may not have had enough pancreas left to be able to reverse her type 2 diabetes. And we see a lot of guys who are, they're in their 40s and they say, you know what, I'm just not, I guess I'm getting old, I'm achy and maybe erectile dysfunction and don't have much energy and I'm kind of not doing that well at work, don't have mental energy, I don't really feel like doing the things I used to do. Well, look at your tummy. That thing's an estrogen factory. And estrogen, guys, does 2 bad things. It suppresses your own testosterone production and it blocks the effect of the testosterone that you do have. So that's one of our arguments for getting rid of the tummy.
What about for women? Waistline.
Waistline for women, actually, especially in postmenopausal women, a little bit of excess weight around the middle is probably protective. Yeah, just the question is how much. And it's you'll notice I'm using the really simple examples. The more complex examples I'm dodging because they're harder to answer. But women who are, in postmenopausal women who are way a little bit heavier have stronger bones, for example. They tend to be more cheerful. And then you get to the point where they're heavier, and then that's a big problem. So there's a gray zone there that I have a hard time defining. I'm not sure anybody has. So back to the diabetes example to avoid her difficult questions. What this is from the Nurses' Health Study where they followed this huge population for a long time. They're at about 30 years or 35 years now for this population. And so what they were able to do is go back and say, after when they identify somebody who's has a new diagnosis of diabetes, so this is a very carefully followed population. It's not that they had their diabetes missed, for example. So they carefully follow the population and they say, wow, this person just developed diabetes. Can we go back in their history and see that prior to this diagnosis of diabetes, they had risk factors that showed up before that? And the answer is, at 15 years before the diagnosis of type 2 diabetes in a patient, their risk for heart attack or stroke is already up by a factor of 2.5. In other words, if they had been told to lose a little bit of weight, get a bit more exercise, eat a bit better 15 years before, their health outcomes would be dramatically improved. If you wait until you're type 2 diagnosed diabetes, if you wait until you're type 2 let me try again. If you wait until your type 2 diabetes is diagnosed, you've really made a big mistake. But if that's when you need to start working on it, that's better than nothing. But remember, you've already accumulated a lot of risk at that point. And this is a plot. This is from New England Journal a few years ago. It was really interesting. They looked at this population and they said, at what point in HbA1c, so HbA1c is a measure of average blood sugar that your doctor can do for, I think it's about a $20 test. At what point do the risks start rising? Because we don't define diabetes until the HbA1c is 6.5%. So what they did is they looked and for example, if you look at the stroke risk there, when you're at about 6% or 6.3%, your risk for stroke is already 2 to 5 times normal. Does this make any sense that we would wait until they follow the strict definition of diabetes, which is 6.5%? No, when your risk of stroke is already doubled, we should be shaking you by the lapels and say, take charge. Because we don't have any drug at that point that's going to do you much good. But we do have lifestyle that will. And so we use a lot of pharmaceutical medicine in type 2 diabetes. It's an extremely profitable area. So if you're looking for a conspiracy, that's a good one. But it's pretty straightforward. If I'll just follow money, right? It's not really a conspiracy because it's way out in the open. And it works for people because it's easy. Hey, I can get an Ozempic injection once a week. Problem solved. And somebody else will pay the $1,000 a month that this costs. Why should I worry about that? It's somebody else's money. And why should I worry about the fact that it might give me cancer or whatever? Because it probably won't. I'll probably get away with it. And if you're one of those people that think that way, I probably can't help you. But if you're somebody who says, you know what, I really want to be healthy. I don't want to be just taking drugs and more drugs and more drugs for the next 20 or 30 or 40 years until I take a dirt nap. And so for those people, they need to say, wow, if I get my weight down, improve my muscle mass, and eat better and cook more at home, I won't need all those drugs. I won't need to worry about all those drug side effects. And my risks of type 2 diabetes, as far as we know, go to 0. As far as we know, if you don't have type 2 diabetes, you don't have type 2 diabetes risk factors. You don't get the stroke that type 2 diabetes would give you. You may still die eventually. I mean, we all go. But you're not going to be plagued by the kidney failure, heart disease, eye disease that a type 2 diabetic would have. Your risk returns to normal. And normal risk is never 0, just in case you need that clarified. So aim for being ex-diabetic if you have diabetes. If you're heading towards diabetes because of any of those other risk factors, waistline, blood sugar, blood pressure, triglycerides, HDL, cholesterol, any of those 5 factors, then take action now so you don't have to worry about it later on. And another thing we run into is this idea, is type 2 diabetes remission or reversal a real thing? We use remission and reversal synonymously in our practice. And out there in the world of academy, then some people use one word and some people use the other. So when you look at the major guidelines for diabetes, for example, from the American Diabetic Association, you see diabetes reversal mentioned, but it's really hard to find. And they don't tell you how to do it. And that seems really weird. One of the projects I use, and I teach a class at Pacific University, and part of the class is critical thinking around healthcare. So this is a doctoral level course for people getting their doctorates. And it's a doctoral level course, and I asked them to go to the literature from the major diabetes organizations and find information on how you reverse diabetes. And they can't find it. It seems so weird. Because shouldn't this be, if you're the president of the American Diabetes Association, wouldn't the biggest thing you would want in your life to achieve is not to be needed? And shouldn't that be your goal? And yet, why do these major organizations not push as a public health policy the idea that we should try to reverse people's diabetes, recognizing we're not always going to be successful? So this is probably the best study ever done, was in Britain. It was called the Direct study, and they took a bunch of people with type 2 diabetes, and it was a randomized control trial, and they reduced their calories, and they didn't have an exercise arm. So all this is pure diet. And at 2 years, just to fast forward to my favorite bottom line in this study, there's a whole lot of bottom lines, but my favorite bottom line is at 2 years, if people lost 30 pounds or more, 70% of them remained ex-diabetic. 70%. Can you imagine how that would transform just the healthcare monetary basis in the United States? Not to mention the human misery. If people said, wow, 70% of you type 2 diabetics could become ex-diabetic. Let's teach you how to do it. And so we use, what the Direct group did was use a very low calorie diet, which is really hard to follow. And so we use the Mediterranean diet, and in your handout, there's a number of studies that we use to support why we use the Mediterranean diet, because what we're looking for is not just reversal of type 2 diabetes, which we could actually do with Twinkies. I kid you not. We could feed you a Twinkie diet and almost certainly reverse your type 2 diabetes. It would be tough, but we could do it. But what we want is to reverse diabetes and improve overall health outcomes. Yes, ma'am.
Recently, I've noticed I have type 1, which is a different process, but the same practical management techniques. I've been seeing articles about people with type 2 who are older, and, they would be older. They're now thinking that many people are misdiagnosed, that type 1 is actually occurring in older populations. They're just not being treated properly because the presumption is that they have type 2. It's a slower process with the decline of the pancreas. What do you think of that?
So what this lady is referring to is the pancreatic failure that occurs in older age, and it's technically you could call it type 1. It's and then there's another genetically type that's fairly rare of diabetes as well. But the kind that you're referring to is, I mentioned earlier, my tall, thin, male, 70 plus, type 2 diabetics that have zero insulin in their blood, and yet they're not requiring insulin. And so we call them type 1.5s in our practice. It's a sloppy term, but it's a way of, so with pancreatic failure, you get what effect is a type 1, but not through any autoimmune process that we can find. Am I answering your question?
I missed that. It's not an autoimmune process with the latent.
The ones I'm seeing, we can't find any autoimmune markers. So they just appear to have plain old pancreatic failure. But either way, we actually treat them the same way as a type 1 or a type 2. In other words, if you take most type 1 diabetics, so the type 1 diabetics by convention are people who through an autoimmune process have lost their beta cell production, insulin production essentially. I've simplified it, but that's sort of the process. And those people need insulin. We don't have any way of creating more insulin production for them. But if we treat them as a type 2 diabetic, in our practice, the type 1s generally require only 1/3 as much insulin as they did before. They become less brittle. In other words, their blood sugars are more stable. It's actually safer medicine. It's also a lot cheaper, and they feel better. So our methods actually work for type 1s, but they don't eliminate the need for insulin production, insulin replacement. Does that work for you, that answer? When you've got a real type 1 in the audience, you want to make sure it works for them, because most type 1 diabetics know a lot about their disease. One of the things I teach my residents is when you are taking care of a type 1 diabetic, the chances are they know more about their disease than you do, despite your MD. So watch out. Be ready to learn. So there's a bunch of different studies looking at the Mediterranean diet versus other studies, including vegetarian and the high protein studies and so on, for type 2 diabetes. And the Mediterranean diet looks like it gives better outcomes. So omnivorous diets look like they work better. And so when we use a Mediterranean diet with reduced refined carbs, what we're trying to do is use a diet that gives more evidence for better health outcomes. So when anybody ever suggests anything for you, if they say you need this supplement, you need to avoid this food, you need to eat this food, look for evidence that it actually improves health outcomes, not a theory, not a biochemical concept. You want real people in real time having real results. So it has to have evidence for broad health benefits. It has to have evidence for diabetes, of course. It has to be easy to adopt for most families. If you're suggesting something that doesn't work for people, that's not sustainable. It has to be economical. Fruits, vegetables, beans, and grains, by and large, cooked at home, are pretty cheap. It has to taste good. If you tell them that they can't have salt or fat, whoa, food starts tasting like cardboard to some of us at about that point. And this approach also is less likely to lead to what we see in Portland, which is food neurosis, where you're consumed by what you can and can't eat, and you talk about it at parties. You know, I really don't want to hear about your gluten intolerance at parties. I don't want to hear about the fact that in Italy you can eat the bread and in America you can't. I mean, you know, these topics become really tiresome to me, but that's just me. You want to have a lot of vegetables and whole fruit, not fruit juice. And vegetables and whole fruit are associated with better health outcomes. And also, if you eat vegetables and whole fruit before you eat anything else, we'll talk about this in a second, you're going to eat less. It's a real surefire way of losing weight. If you eat vegetables and protein before you eat anything else, you feel more full. You simply don't need to eat as much. Whole grains. So once again, I come from Portland right now, and in Portland, then grains are condemned as being bad for you, by and large. We would argue there is no food group that has as much evidence for benefit as whole grains. Name any disease you want. And people who eat whole grains seem to do better with that disease in terms of outcome studies. So we're big on whole grains. And if you're gluten intolerant, there's plenty of grains that don't have gluten. The whole issue of whole grains can be confusing, and I'm not going to go into detail in this slide because if you're into this area, you need to sort of think about it. But by and large, whole grains in their whole form that look like it came out of the farmer's field, what looks like birdseed, because it is the fundamental whole grain. If you grind that into flour at home, it's definitely still whole grain. If somebody else grinds it for you and it's sitting on a shelf for weeks and weeks and weeks and the oils and so on are oxidizing, it may not be. There seems to be something that happens with commercial whole wheat flours. And then if you turn it to white flour or unbleached flour or wheat flour, so when you see the words wheat flour, that means white flour. And that's one of the tragic little labeling things that misleads people a lot. And that's why we come back to, and if you've got a health problem, think about avoiding all foods made with flour, and you're going to get rid of a whole lot of problems in most cases. Even whole wheat flour. Made with flour. So foods made with flour, by and large, are going to have a big effect on your blood sugars and insulin, and unless you make them yourself. There are exceptions to that. For example, right now we have in our fridge some Great Harvest. I don't know if you have a Great Harvest bakery here, but a Great Harvest whole wheat bread. They make their own flour. It's pretty good bread. You can eat too much of it, especially if you go on a Saturday morning and they've got some warm samples out. But it's still really good bread. It's probably pretty close to what you'd make at home. White rice. White rice is an example of, just like white flour is probably pretty bad food. White rice is a real problem for us because it's basically congealed glucose. It turns itself into blood sugar probably faster than any other commonly used grain. And for people who are really into white rice, it's very, very hard for them to give up. It's sort of like Diet Coke. There seems to be something addictive about white rice. So we say, just eat less and less and less of it. Yes, sir. Brown rice is a lot better than white rice, yes. So if I get a chubby person with diabetes who say, but I don't like brown rice as much, I say, problem solved, in which case they go find a different doctor. Beans, lentils, and other legumes associated with a broad range of health benefits. There's I don't know if any of you have heard of a Dr. Gundry in Palm Springs, but he's sure that lentils kill you, and I think, wow, I wonder how much medical literature he actually reads. because people who eat these foods have consistently better health outcomes. Solid food is more filling than liquids. This is really important if you need to lose weight. Get rid of the liquid calories. The liquid calories, including soups, just don't fill you up as much. And so if you need to lose weight, then skip the liquid calories. If you need to gain weight, then soups and smoothies are perfect. And in our book, we have a smoothie that we use, for example, in our post-surgical patients and our cancer chemotherapy patients and so on, because they need the extra calories. Most people don't need the extra calories in our society. And we condemn smoothies for the same reason. Commercially prepared food, so it's really hard for me not to go back over and over and over again to clobbering commercially prepared foods, foods made outside your home. But if we're talking about diabetes, then the commercially prepared foods, if you just look at the diabetes outcomes alone, are strongly associated with more diabetes. Cook food at home. I've run through the last few slides fairly rapidly, skip because the details are so, that we get bogged down in the details. Does anybody have any questions about them if I went through them too fast? Yes, ma'am.
I eat brown flour and like it, but how can all those people in Asian countries eat white rice and, do they have bad outcomes? Or?
Well, it would appear that in terms of longevity, so the question she's asking, tell me if I got this right, is they've got all these Asian people eating a lot of white rice and they seem to be doing just fine. Am I right? And that's a really good question, and one that we can't readily answer. In some of those societies, the societies have the best health data, which would be Japan and South Korea, where are the two white rice eating societies that have really good quality health outcomes data. We do see an awful lot of suicide and mental health disorders. And they do get diabetes at a much smaller body size. And so then you have to go back to, so for example, in Caucasian populations, at a BMI, which is a measurement of body weight, it's not a great measurement, but it's one of them. Then those, in Caucasian societies, a BMI of 30 or more is usually more associated with diabetes, whereas the average in Japanese society is a BMI of 26, which in our society would actually be pretty appropriate body weight. So there's a lot of things that are different in different genetic populations that may be confusing to us. But if we keep going back to saying in any society, and this has been studied, if we see a more omnivorous diet with less refined carbohydrates, including white rice, does that population do better? And the answer is consistently yes. So if you are on a white rice diet and eat a whole bunch of fish and probiotic foods, maybe you can get in greens, because they also eat a lot of vegetables, then maybe you can get away with it.
What about canned beans?
Canned beans, like you mean like kidney beans, black beans, and so on. Yeah. We don't know the answer to that. So the question is, if you get canned beans, does that fit the industrial model of food that we're talking about? And the answer is we haven't the foggiest. Nobody's ever done that study. We are suspicious that they're not, but we use them ourselves to some degree. Sometimes we cook our beans, sometimes we get them out of the can. And we go back to the fact that people have been eating canned beans for about 150 years. And so that gives us some encouragement that they're probably not too bad. How's that for a soft answer? Like Dodge? I sat right on the fence on that one.
Quaker oats.
So Quaker oats. So think of all food processing as a continuum. So on Quaker oats, so on one end, you've got Cheerios, really highly processed, quite delicious oat product. That's probably not great for you. Then you've got rolled oats, which are better than the toasted oats. And then you get steel cut oats, which are probably a bit better than Quaker oats. And then you get oat groats, which are better than all of them. So we use oat groats in my house. We cook them overnight along with some barley and rye. And that's how we eat our oats primarily. Now, if somebody hands me a bowl of oatmeal made with Quaker oats, I'm happy to eat it. Is it optimal? Maybe not. And once again, a lot depends on your personal health issues. If you're so I've got a 98-year-old guy, retired cardiac surgeon. Every single one of his blood vessels is clogged. We happen to know that. He thinks it's a scream because he's a cardiac surgeon, so it's sort of ironic. He's doing fine, which is a separate discussion about how the body handles clogged blood vessels. But the point being, he's 98 years old, he's bright-eyed, he's bushy-tailed, he moves around, he takes care of his wife who's ailing. He lives independently at home. He does everything any of us would do except drive. Did I mention he's 98 years old? You know, am I going to start telling him don't eat his Quaker oats? No, because whatever he's doing is working for him. So would he be better if he ate my oat groats? Maybe. He's 90 years old, he's doing great. So we all are flexible individuals, and some of us have higher tolerance, like the guy to your left who eats all that sugar.
Heredity.
Yeah, the guy that I'm talking about, his parents were Ukrainian Jews from Odessa, and they both lived to over 100 years old. So he got some good genes.
Based on that, though, whenever I go to the doctor, they say, have you had diabetes in your family? I go, yes. So how does that relate to this?
Well, I believe that everybody should behave as if they have had diabetes in their family. So it doesn't really make any difference to us. So we don't pay that much, and this is going to sound really terrible to some of you, we don't pay that much attention to things that we can't change. We can't change your family history, and we treat everybody the same. So, you know, got family history of diabetes or don't have family history of diabetes, we're still concerned about your exercise level, your weight loss, and so on. Alcohol type 2 diabetes. So alcohol has become, seems to be a new enemy. So as near as we can tell, the public health authorities seem to need to have something to concentrate on. So in the 80s and 90s, it was fat. Somewhere, you know, mixed in there, there's salt. They never seem to condemn sugar in the way that they should, in my opinion, or processed foods. Right now, alcohol is getting really clobbered. And we can certainly see why. I mean, alcohol is really toxic to a group of people, alcoholics. And drinking too much alcohol is really a bad thing, just like a lot of things, too much of a lot of things is bad. But we shouldn't throw the baby out with the bathwater. And in case of diabetes, for example, we have consistent evidence that drinking a small amount of alcohol, by that we mean probably up to 7 drinks a week for women, probably up to 14 drinks a week for men, is associated with better health outcomes overall, less diabetes, less total mortality.
Why the difference between men and women if they're the same size?
Probably estrogen's effect on the liver. So the question is, why do women have lower tolerance for alcohol than men? And it appears it may be an estrogen effect on the liver, so women have more estrogen. That blocks hepatic metabolism of alcohol. That's probably a super simplistic answer that we will probably find out is wrong, but it works because it makes it sound like I know what I'm talking about. So for you, those of you who are sort of interested in this data, there's one relatively recent Danish study that supports what I just said about a little bit of alcohol is not as good for diabetes, and I would argue overall mortality. A little bit's good, and a lot's really bad. And I've given you the curves for that. And once again, never trust somebody who presents one line of evidence. If this was the only study I had, you should stop listening to me right now. In actual fact, we have a whole bunch of studies that look at the same topic. In fact, I'm not aware of any study that doesn't show that small amounts of alcohol are protective against diabetes and diabetes complications. But I mentioned small amounts. Did I mention small amounts? Small amounts. Small amounts of alcohol. If you're using this as an excuse to have 3 or 4 drinks at night, you're lying to yourself. And if you say that's what I said, you're lying to your wife. One of the studies I mentioned here is the Morgam study, Morgam project, published relatively recently. It's really interesting because it's one of the few studies that really outline types of alcohol. And it did seem to show that wine has better health outcomes, including for cancer. So if you're interested in, at the very bottom bullet there on this slide, then it talks about the Morgam project. If you're interested in this topic, it's a really good study to know about. Caffeine, coffee, tea, they all seem to be protective, not just against your development of type 2 diabetes, but also of your risk of diabetic complications, and pretty much of all health outcomes. Coffee and tea appear to be protective broadly against most bad things happening health-wise. Yes, ma'am.
What about caffeine and chocolate, cocoa, that kind of thing?
So chocolate and cocoa don't actually have caffeine. They've got a very similar compound called theobromine. which is part of this family called, that we call as the methylxanthines. For you, those of you asthmatics, then you're using albuterol, then albuterol is another methylxanthine. So they all appear to be protective. The evidence for cocoa isn't as strong as it is for coffee and tea, but it's still protective, and we're big, strong believers in dark chocolate. We're also strong believers in calories. So when we're looking at weight issues, we really think that calories are super important, but it's also really difficult to count them accurately. And our patients that try to count calories as a weight loss tool don't seem to be successful. It's not that it's not a good idea. It's not that it doesn't make sense. It's really hard to do accurately. And so we use portion control and low calorie density options. So, for example, the first thing we say is cut all your calories by 20%. Just whatever you eat 20% less. Another tool is avoiding all the processed foods, because processed foods simply go down easier. So people who eat a lot of processed foods, there have been studies that they just look at what people eat. And the more people eat outside the home, the more calories they eat. And that seems to be just because when you're in the food industry, then you know that sugar, fat, and salt sell. And if you can combine all three of them, bonus. So you'll sell a lot of product. If you eat a whole fruit or vegetable at the start of every meal and snack, so one of the things we do for our patients is we could loosely call it the 6-apple challenge. So I say to people, okay, for a week, every evening, make sure you have 6 apples available for the next day. It doesn't have to be 6 apples. It could be 6 avocados or 6 bananas or 3 apples and 3 pears. We don't care, but you get the idea. It could be 6 heaps of celery. And before you have breakfast or lunch or dinner or a snack, have at least one of those apples or heaps of celery or pears or bananas. 2 for bonus points. And tell me if at the end of a week if you haven't lost a pound or 2 or 3. I don't think we've ever seen a failure. Ever. So we had a patient with type 2 diabetes recently who came in and she's on about 40 units of insulin a day. She said, I've had diabetes for 10 years. I'm sick of my blood sugar monitoring and I'm sick of my insulin and this is just wrong. She works at our hospital, so she's sort of easy to keep an eye on. And initially she was pretty successful. She got rid of a lot of processed food, got a bit more exercise, lost a few pounds, cut her insulin levels from 38 or 40 units a day down to, I think, 14 or 15 units. So big improvement. Blood sugar stabilized, which is one of the side effects that are handy, but couldn't lose any more weight. So we just did the apple and pear challenge with her and the diet log. And boom, she started losing weight again. I think 1 or 2 pounds a week right now, am I right, Shelley? Yeah. And it's just her insulin level, her insulin requirements, it's just marching down, 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 down. And for those of you who are into intermittent fasting, it works. I don't like the idea myself, so I don't talk about it too much, but it's just one way of reducing your calories. My partner in practice, he's convinced it has metabolic benefits otherwise. It's actually an interesting example of where both of us have the same training, the same literature that we're reading, and one of us says, I think this is just a calorie control tool, and the other one is saying this has metabolic benefits beyond calories, and we can't agree. And it doesn't really matter. If something's working for you, keep doing it if it's healthy. Apple cider vinegar is kind of interesting. And we talk about this at some length at our website, greatmed.org. So it's a free service. So right now it primarily is looking at diabetes reversal. If you go there and you can read all the papers on apple cider vinegar, but to us it's kind of one of those amusing, well, I guess sad, but amusing aspects of modern medicine that this very simple, cheap food that has such a dramatic effect on blood sugar is not being promoted for that purpose by the conventional medical community. And we just think, this doesn't make sense. But then we look at the naturopathic medical community and we don't see them promoting it either. They're putting people on chromium supplements that we know don't work. And we're saying, why aren't they using this? This is the core of naturopathic medicine. So for you, your job is to say, hey, are these people's data good? And if they are good, use it.
Will freshly squeezed lemon juice do the same?
So the question is, does freshly squeezed lemon juice do the same thing as apple cider vinegar? And we have no idea. I've never seen a study on that. What's interesting is the apple cider vinegar might work through the microbiome, which we'll talk about in a minute, the bugs in your gut. And if that's the case, lemon juice probably doesn't have the same effect, or it might. And it's actually interesting that red wine has the same type of benefit for the gut as well. So, speaking of the microbiome, feed your microbiome. So the microbiome is your bugs in your gut, the healthy bugs, and it depends on healthy fats, which are all the fats we've talked about, including butter. It involves being fed bugs. That's hard to say fast. So by feeding your gut good bugs, you get this broad population of bugs in there, and we don't know which bugs should be there. So I'm not promoting probiotic supplements. Whole food is generally dirty food, and it's got bugs, and that's a big component of this. Foods that are cultured, like yogurt and kefir and fresh sauerkraut, have loads of bugs as well. Then you get the foods that actually help the bugs grow. Sometimes people call these prebiotics. We call it food. So pretty much any fiber food has it, and it has the range of implications for disease, including gallbladder disease, kidney stones, obesity, diabetes, heart attacks, strokes, resistance to infection, whether you got COVID or not, and whether you got COVID and had a serious case or not. These are all related to your microbiome. So baby your microbiome, look over the list there. And if you look back at the German naturopaths from like 1880s, where they said all disease starts in the gut, they were probably right. So baby your gut. Exercise, don't skip it. Or do skip it in the case of skipping rope. There's a little inset there from a paper that Shelley's the first author for that was published on the concept of being short of breath and sweaty. The idea that exercise is not walking at a passive rate. We would argue that if you're not getting short of breath and sweaty, you're not exercising. And the reason we came to that is, you had all these recommendations from like the American Heart Association that said, walking 20 minutes 3 times a week is exercise. And we failed to see people actually getting better. This is where you go back and say, this is a fine idea, and it's being published by a major organization that has big brains behind it and big money behind it, but are we seeing it work in the real world? And if we're not seeing it work in the real world, we should not keep doing the same thing over and over again. So you start looking at the data and you realize, wow, if you're not getting short of breath, you're probably not exercising at all. And if you're not getting short of breath and sweaty, you're probably not exercising much. So we would ask you, when you're exercising, ask yourself, are you getting short of breath? If you're not getting short of breath, you need to do something differently. And we have a list there of all the different kinds of things you can do. Don't give yourself any excuses not to exercise 3 times a day. 3 times a day. I didn't say 3 times a week. I said 3 times a day. Even if it's only for 1 minute. And so patients come in all the time and they say, they look at me suspiciously at this point and they say, 1 minute of exercise isn't going to do anything for me. And I say, give me a week of 1 minute of exercise 3 times a day, such as skipping rope, running stairs, lifting weights. Put in whatever you want to that's going to get you short of breath and sweaty in 1 minute. We often promote the use of a body blade. Basically it's a 4-foot piece of fiberglass, and you shake it. And people, for the first 10 seconds, they're thinking, what a waste of $100. We don't sell them, but the people that sell them, it's about $100. They're saying, what a waste, $100. And then I say, try it for 45 seconds, and then tell me if it's still a waste of time. And at 45 seconds, their arm is starting to hurt. So we say, see? So even if it's only 1 minute, 3 times a day, short of breath at minimum, sweaty preferably, and you're going to see, if you're not already doing something like that, you're going to see a transformation of your health, I would argue. And it's simple, it's easy, it's cheap. You have no excuses not to do it. Who doesn't have a minute 3 times a day? Nobody. And yet, I would argue that half the people I see for healthcare problems wouldn't need to see me if they were doing that. I don't think I'm exaggerating. So find something you'll do it, and don't find any excuses. So for example, let's go back to my father-in-law. He's got lousy balance problems. So when he's chainsawing in the woods, so he's chainsawing these big fir trees, which he burns all winter. He's got really lousy balance. He says, don't worry about it, Miles. The chainsaw is my third point of contact. Like a three-legged stool. I've got a chainsaw. So he's got this 20-inch blade spinning around, just waiting to take off his leg. Did I mention he's 86 years old? He can do whatever he wants. He hasn't taken his leg off yet. What a way to go. Anyway, so do something, do it regularly, and don't find any excuses. If you need an excuse, don't call us. We will give you a reason to do it. If you have poor balance, get trekking poles or a chainsaw. If you have, if your upper arms are weak, use lighter weights. If you don't know what to do, go find somebody fit who will tell you what to do. You may not like what they say, mind you, because it'll be work. And that goes back to that pouting girl at the beginning of the talk. You know, if you don't want change, you're in the wrong place. So ask yourself, who does this and how do they do it? Don't give yourself excuses. Shirley wants to take another break. Because did you know that sitting is the new smoking? People who sit for more than an hour have a risk of things like heart attack and diabetes and stroke that's equivalent to that of smokers. How's that?
We had a lady who loves walking. She walked an hour every morning and an hour at night, and started to get in the habit of eating protein bars. And her hemoglobin A1C went up to 13. And I said, but you're walking every morning and at night. Are you getting short of breath and sweaty? And she said, no, I'm in good shape. I don't get short of breath or sweaty. I said, put this vest on. I put the vest on her. I said, march up that hill 3 times. And then she got short of breath and sweaty.
So the vest that she's wearing is?
It's just a weighted vest. You could put a bag of flour in a backpack and do the same thing. But carrying something heavy. Then she took her 6-apple challenge. She had been afraid of fruit because she thought it would up her blood sugar. She took her 6-apple challenge, carried around the heavy vest, and marched up the hill, and her hemoglobin A1C went down to 9 in 3 months.
So exercise in type 2 diabetes and every other disease process pretty much. So for example, we saw a case of Wegener's very, very destructive autoimmune disease. Her kidneys were going south. Her next stop was dialysis. I don't know if any of you know people on dialysis, but it's a not great way to spend your life. Kidney failure is a real detriment to quality of life. So one of the things that she did that reversed her disease, and as far as we can tell by biochemical measurements and her symptoms, appears to be completely reversed at 1 year, is a 3 times a day exercise program. So once again, the things we're talking about for type 2 diabetes are the same things that help, as near as we can tell, every other process. But physical activity is strongly associated with lower risk of diabetic complications, even if you still have diabetes. If you do little short bouts of exercise in type 2 diabetes and probably every other health process, it appears to work better than doing one big process. So in other words, the way they've done these studies is they, for example, give people vigorous walking 3 times a day for 15 minutes or once a day for 45 minutes. And the 15 minutes 3 times a day group did better. We don't fully know why that is, but if you think of historical precedent, up until, say, the post-World War II period, people were active all day, every day. They didn't have cars, they had to walk, they had to brush the horses, they had to bring in the wood, they had to bring in the water, and so on. And so physical activity throughout the day probably is a much better pattern than once a day or going to the gym once a week for 2 hours. And it's worth remembering that sitting is the new smoking. So sitting for more than about an hour is associated with significantly worse health outcomes. And television is kind of interesting. I cannot find any papers that don't condemn television. And you can name, whether you're talking about mental health, childhood behaviors, bullying, violence in the schoolyard, diabetes, heart attack, mortality in adults, you name it. I can't find, and as you might guess, in our own home, we don't have a television, and there's a reason for that. So I think that the television is kind of fascinating because you just don't see it discussed. And yet the papers are out there. The evidence is out there. And there's a book from probably 20 years ago or more called Plug-in Drug that's just great. Another one is called Amusing Yourself to Death. So there's all these books about just how bad television is. And one of the weird things is they just get ignored. There's a book from the 70s called 4 Arguments for the Elimination of Television by a San Francisco advertising guy called Jerry Mander. And he walks through the science of the 4 areas of science as to why you shouldn't have a television. It was a cult book. If you go into some used bookstores now, you'll see piles on this side because they still sell. It's out of print. But it doesn't seem to have any impact. That's the drug part of television, I think. So let's look at a really practical outcome of exercise. So this is a study where this German guy called Hambrecht, and this is published in one of the flagship journals of cardiology, just in case you think it's a fringe study. He took two groups of people, and they all got, one group of people, and they all got chest pain when they exercised. And half of them went and got a stent, as we see happening, and half of them got sent home and said, we're not going to give you a stent. We know you've got a blocked artery, but we're not going to give you a stent. And you're going to exercise for 20 minutes a day on an exercise bike at 70% of VO2 max, which basically means they had to get short of breath. But this wasn't exhausting, it wasn't exhausting. And guess which group did better? The group that exercised, not the group that got the $20,000 stent. And the interesting thing about Hambrecht he says, I never could get funding for a follow-up study. Now, once again, if this was a standalone study, you should be walking out of here and saying, Miles, why are you reporting on a single study with a weird outcome? In actual fact, there's a bunch of data that support the same concept, that sending people home for a simple exercise program works better than our fancy interventions and is safer. So the exercise prescription for everybody is at least 30 minutes a day, preferably broken into 3 times a day, short of breath and sweaty, and anything is better than nothing. How's that for a summary? You can read the slide if you want, but that's pretty much it. And just no excuses. If you've only got one leg, well, you still got arms. So I have people who come in and they just had, let's say, a joint replacement. Since I've had my joint replacement, I can't get to the gym. And so we just glare at them. Unless it's shoulder replacement, I say we've still got arms. If it was shoulder replacement, I still say you've still got legs. In other words, we don't look for any excuses. We look for answers. We look for solutions. And so you can see the no solutions, the no excuses idea as being mean, or you can spin it and call it, we're looking for solutions. And then it sounds a lot better. This is kind of a summary on the diabetes part. How do I reverse my diabetes? You'll notice there's no one answer. There's a whole bunch of answers. And you probably have to do most of them. Most of our patients seem to need to do most of them in order to reverse their diabetes. It's all simple stuff. It's all cheap stuff. It's all stuff that will leave you healthier than you were before. And none of it involves drugs. None of it involves fancy interventions. All it involves is having a backbone. By that I mean self-determination, self-control, a desire to be healthy. And then the indirect benefits are less cancer, less heart disease, less stroke, less mental illness, less risk of dementia. And then there's all these little things that relate to microvascular disease, and we don't have time to go into them, but they relate to things like whether you get hearing loss or not, whether you lose eyesight or not, whether you have unexplained kidney failure or not. So these are all microvascular complications that are associated with these same health outcomes. That's a separate 1-hour lecture. So, become weight appropriate and active, eat food made at home, minimize sweets and foods made with flours, and identify your risk of diabetes as soon as they become evident, which is typically people in their 30s or 40s. Most often in our practice, it's probably being a little chubby and having high blood pressure. So we're going to talk briefly about weight loss. We have about half an hour left, huh? Okay. So First of all, accept that weight loss involves basic physics and not magic. And this is really interesting because I have people every day who tell me they can't lose weight. You know, you reduce your calories, you're going to lose weight. So the answer every time, you've got to stare at that person in the mirror and say, where are the mysterious calories that I'm getting that I don't realize I'm getting? And if you don't, if that first line doesn't make sense to you, once again, then I'm nuts. And then why are you here? You want to find a way to eat less without being hungry, because being hungry is usually destructive. That involves physical activity. Usually most people need distraction. I don't know how often you've been hungry and then something comes up and you need to do something and suddenly you forget about being hungry for a while, an hour or two. And it might be something simple. Let's say I'm hungry and Anna says, let's go play ping pong. Anna's my wife, in case you're wondering. Well, I'm going to forget about being hungry and we're going to go play ping pong. Then I'll be even hungrier, which is okay. She might beat me. And remember that weight is lost in the kitchen, not the gym. I can't tell you how many people were sitting at home with COVID, snacking a little excessively, gaining weight and saying, oh, it's because my gym is closed. It's not because your gym is closed. It's because you're eating too much. It's really hard to lose weight with exercise. How many of you count calories when you're exercising on some machine or something? You say, wow, if I do this for an hour, if I run like this for an hour, I'm going to lose 300 or 400 calories. Well, how much calories is in a muffin? You can get 600 or 800 calories in a muffin. How long does that take to eat? A couple of minutes? And then you wash it down with a caramel latte? Another 400. So now you've got 1,100 calories that you wash down because you burned 300 calories on the treadmill. You know, it doesn't work. So no mindless eating unless it's celery, and by celery we mean fruits, vegetables of all kinds. And accountability. Demand of yourself at least a pound a week or more of weight loss. If you're not losing a pound a week or more, you're not on an appropriate path. You got to find some answers. And that involves figuring out a way to eat less. One of the things we often suggest is find some skinny person that you know and have them criticize you. You're not going to like what you hear. You know, pretend you're some supermodel or Olympic athlete or something. And they were at the same occasion, you know, same event you are, which might be dinner, or it might be a social event or something. And say, how would they eat if they've got a photo shoot in 2 days? They'd probably be snacking from the celery tray. We're big on celery, because celery is really good at dropping blood pressure. So how do you eat less? You keep a diet log. You eat whole food prepared at home. You avoid sweets, sweet drinks, liquid calories of any kind, and foods made with flour. You eat a large serving of fruit and vegetables before every meal and snack. Try my 6-apple challenge. In fact, we should probably do that for TikTok, don't you think, before somebody else does? Shelley, let's do a TikTok challenge. We've never done TikTok, have we? I don't think we've done TikTok. We do? Okay, I don't do social media, so I actually don't know what we do, but just try it. You'll get bored to death with apples, so you can switch to anything you want. But my other RN in our office, who's also named Shelley, often, if patients say they can't lose weight, so Shelley gets up at 4 a.m. The other Shelley gets up at 4 a.m. So this Shelley is Taekwondo Shelley. The other Shelley is runner Shelley. And so she gets up at 4 a.m. every morning and she runs 4 miles, which is kind of, in my view, it's kind of crazy. I get up at 4 a.m. but not to run 4 miles. So, her body fat percentage is probably 10% or 7% or something. So any patients who say they can't lose weight, I say, come with me. And we just walk next door into the nurse's office. And on her desk is probably going to be a heap of vegetables of some kind. It could be cauliflower or celery or carrots or something, raw vegetables. And she, you know, dealing with her all day, she's looking at me and she's munching. It's like watching a guinea pig. And that's how she stays from eating the wrong foods. If you can't wrap your mind around those kinds of ideas, you probably can't lose weight. And eating protein with every meal and snack. Protein and fat are highly satiating. In other words, they fill you up. And so if you're let's pretend you're eating a great diet, you're losing weight, but you're hungry all the time. Throw in some protein. Have some cold red meat. cooked. Have some cooked protein always at hand and eat some of it. And people say, well, that's more calories. I say, yeah, but it's going to fill you up more. And we've never seen people who are otherwise eating well and losing weight who add red meat or a can of tuna or something who don't continue losing weight and are able to continue losing weight and not be hungry.
Sugar substitutes. Like, I don't like unsweetened yogurt, but I don't want to eat the sweetened yogurt, so what's the story there?
So the story is on sugar substitutes, whether it's stevia, monk fruit, sucralose, name one, is you have to overcome your sweet tooth. So don't eat sugar substitutes. If you're going to eat sugar. So we usually have honey or maple syrup at our home. There is sugar in our home if you look hard enough, but you'd have to spend quite a while going through cupboards to find it. And when you have honey, you don't tend to eat as much of it. So for the person who wants, for yogurt, for example, I don't like yogurt or kefir, either one. So we threw the two of them together, put in some berries and a banana, and that usually tastes pretty good. If the berries and banana aren't sweet enough and I'm really feeling wimpy, we might add a little honey. But most of the time, no. So basically find a way to enjoy food that doesn't involve added sugars. If it does involve added sugars, make it honey. But most of all, remember you've got to overcome your sweet tooth. A little bit like people who say, you know what, I can't not eat chips because I just love that salty, crispy stuff. And I said, well, everybody on the planet loves that salty, crispy stuff. You know, what's it worth to you for your health? Have it on your birthday. You get a pack of Doritos on your birthday. I get Cheerios, you get Doritos. This is an 88-year-old patient of mine. His idea of a birthday party for his family that came in from all over the United States was to go for a fun run. Isn't that fun? 15K fun run. Now, he doesn't look real happy there, does he? But he did it. And that's an interesting aspect of this whole issue of aging, is you really want to have muscle mass. And so exercise is a very weak weight loss tool. So if you're too heavy, it's not because you're not exercising enough, it's because you're eating too much. But in terms of health, of weight distribution, of mental health, of cancer avoidance, diabetes reversal, all these sorts of things, then exercise is really important. And so we talked about being short of breath and sweaty. We talked about 3 times a day. And think about weightlifting, because the weightlifting is by far the best method of actually adding muscle mass, which improves your metabolic rate, which improves your caloric burn and helps with weight maintenance, as well as changing your whole hormonal milieu, your whole hormonal mix in your body in a favorable way. And that's my wife getting trained on weightlifting. And this leads to the whole concept of anti-aging, which is a huge, can I say money maker? It's a huge industry out there, anti-aging. And I would argue that the evidence so far is anti-aging is pretty simple. It involves eating an omnivorous whole food diet that we call a Mediterranean diet, or some variation of that, minimizing processed foods, thrice daily exercise, waist control. We'll talk about purpose in a second, and watch out for doctors and their prescriptions. The whole idea of the drugs is to, in general, there are exceptions, big exceptions, but most drugs are there as a Band-Aid over something that you should be treating with lifestyle. There are exceptions. And as I said, I'd prescribe drugs all day, every day. That's my mother-in-law. Look at that expression on her face, right? Would she have that expression on her face if she wasn't fit? I don't think so. So purpose is really interesting, because if you take people, so this was a study done where they took people who enrolled in this study knowing that they had to donate their brains after they were dead. They didn't have to donate their brains before they were dead, like some of our politicians. So they donated their brains after they were dead, and the question that was being asked was, what patterns of life did we see in these people that led to better brain health or worse brain health? So who got dementia, who didn't, and so on. Well, they had many outcomes of the study, but one of the interesting outcomes was the people who had brain changes consistent with Alzheimer's disease, who during their life in their surveys that they did on these people, expressed a strong sense of purpose, didn't have the manifestation of Alzheimer's disease, despite having brain changes. And it just tells you how much flexibility, plasticity, rewiring your brain is capable of when everything is falling into place. So think about purpose. I was asking a patient the other day she was been a very successful lawyer. She was in her 70s, fit, and sort of just life for her was blah. And I said, tell me about, what's your purpose? So she came in sort of because of fatigue, maybe. She wasn't too sure, but probably fatigue. I was sort of interpreting it as depression. Who knows what label you'd put on it, somewhere in that spectrum. And she says, She sort of leaned back in her chair and said, I guess I don't really have any purpose. And unfortunately, the conversation didn't really go anywhere. Sadly, I think I did my best. But the point being, don't underestimate the fact that you have to be of value. And say, how do I be of that value? Because it means you're being of value to somebody else. God, your family. And it's not entertainment. Some of the most depressed patients in my practice see movies every day. Some of them a couple of movies every day. They just immerse themselves because they don't know what else to do with their life. That's really sad. And then that sort of overlaps with this idea of eudaimonic well-being. So eudaimonic is the opposite of hedonic. So hedonism is when you are looking for taking care of yourself. You're number one. Eudaimonic is where you take care of others. And once again, there's a mortality benefit of taking care of other people. And it's really fascinating data when I give you some references there. And then there's polypharmacy. So most people on Medicare have 5 or more prescription medicines. And it's not a good indicator of outcomes. And so one of the things that we do is we try to reduce the number of medicines people are on. And I sort of go through in this slide, I won't go through the individual bullets here, but I go through some of the evidence points that say, watch out for being on too many medicines, and say to yourself, which medicines do I not need to be on? To go back to my thin, healthy martial arts nurse, she has to be on a medicine called spironolactone for her blood pressure, otherwise she's going to have a stroke tomorrow. And I'm not exaggerating very much. That was a tiny bit of an exaggeration, but not much fun. She's an exception. And that's why we love the pharmaceutical industry for when they do good stuff. And if you're interested in this, especially if you're over 65, there's something called the Beers criteria. It's published by the Cleveland Clinic, I think. But if you just type in Beers criteria in a search engine, you'll see all the drugs that they recommend against being on when you're over 65. And there's a reason for it being on that list. This is not a wacky fringe medicine list. This is a mainstream list that's largely ignored. So we had this lady who came in from the coast. So it's a 4-hour drive to get to my place. And I said, well, why are you here? And she said, well, my family brought me here because I started falling over and I broke my teeth and I broke my nose and I can't drive anymore. And I saw a couple of doctors on the coast and they told me to get a walker. And she's 80 years old, lives alone, and can't drive anymore. And so I'm looking at her list. She's on 11 prescription drugs, of which I think 6 were on the Beers list, maybe 7. I can't remember exactly. And I said, well, you're on a bunch of drugs and a lot of these are sort of overlapping. And who put you on all these? And she said, oh, well, so she sees several different doctors, just keep adding drugs and nobody ever takes one away. And she obviously hadn't been trained to be self-reliant and saying, hey, what am I going to do to keep this from happening? So we did a careful, she had actually already had pretty good neuro workup, but we did another neuro workup, made sure we weren't missing something else, multiple sclerosis or stroke or something. When I had her stand up, her blood pressure dropped like a rock. She was on too many blood pressure medicines. She got sort of dizzy. So well, that's part of her. You don't have to go to medical school to realize that's part of why you're falling. She said, oh yeah, I guess you're right. Her blood sugars were really low. She had diagnosed with diabetes, but she was on so much blood sugar drugs that her blood sugars were down in the 50s, 60s, 70s. She was way overtreated. So you could see why she got in the situation she was in, but it was just plain old poisoning. So I said, well, I think you're being poisoned. How about if we get rid of a bunch of these drugs? And so we gradually, over a couple of weeks, took off one after another. Boom, 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 boom. And she was able to get back to driving. She stopped falling and so on. That was a couple of years ago. I just recently saw her. One of the reasons I saw her is because her primary care doctor fired her. Said, well, we really can't have you seeing this many doctors. And well, she'd been already seeing a whole bunch of doctors. I think she was just offended that I took off half of her medicines. Instead of saying, because all of us, and that includes me, all of us in medicine have made big mistakes. There's not a single one of us that don't have something to be embarrassed about. And so if I can't see a patient who's seen another doctor who said, you know what, I think Miles was wrong about this, and they were right, and if I can't say I'm sorry, then there's something wrong with me. And your doctor should be able to take that same kind of criticism too, because we all need it. And you should be the first critic of your doctor. And that includes me. And that includes if you find out something I'm saying that was wrong. Hey, Miles, I think this paper that you're citing here is you're misstating it for this reason. And occasionally we've had people say, well, hey, Miles, I can't see that this paper actually referred to what you were saying at all. And that happens sometimes because occasionally we might attribute a statement. But that's important for us to hear. And important for you to trust nobody, including me. So what are the barriers to making change? One is motivation. Do you really think that you want to be healthier in 5 and 10 years? Can you look that far ahead? Maybe it's that you like Eggo waffles too much. There's a guy here with an Eggo waffle t-shirt, so I couldn't resist that one. What's your culture? Maybe your culture is a white rice culture, and it's really hard for you to not reduce your use of white rice. Maybe you live somewhere, they call them food deserts, where it's hard to get good food. Well, you've got to find a way around that problem. Each of these barriers are a real barrier. Maybe you're confused as to what good advice is. And that's fair enough too. And when you're thinking about this, look at it as a chance to not just change your own health, but to inspire others. To not be a victim, but to be a victor. So start with some goals. We're wrapping this up in case you're really sick of me. Have some clear goals about what do you want to do with your health. It might be something very specific, like I don't want to have another heart attack or stroke. That's pretty good. I want to reverse my diabetes. Or so far I've been pretty healthy and I want to keep it that way. What barriers, what traps, what challenges lie ahead of me? I have a very strong family history of colon cancer. Everybody dies of colon cancer. So, for me, hey, not only am I going to take care of myself, but I'm also going to get a colonoscopy now and then. So we all look at what challenges lie in front of us and do something about it, realizing that we all are going to die. And, does your mood need help? Does your energy need help? And so on. Just to think of all the things that you could see improvement in. And then do something about it. Start with dinner tonight, breakfast tomorrow. I often see somebody, let's say I see them sometime during the day, and I say, well, having talked about this and whatever disease process you've got, what changes are you going to make? It's sort of my way of seeing have I been very effective as a communicator. They say, very often they say, well, tomorrow I'm going to do X. And I say, well, why tomorrow? Why aren't, there's several hours before you go to bed. Why aren't you going to do that now? Which leads to an interesting conversation of just the urgency. How much time have you got? And I would say treat all of your health issues as urgent issues. And you're going to be way better off than if you say, this is something I'm going to put off to mañana. How are you going to plan your meals? If you don't plan your meals, well, something else I ask is, what do you have for dinner tonight? And I would say 2/3 of my patients don't know what they're going to have for dinner tonight, or they're too embarrassed to tell me, like McDonald's or something. They wouldn't want to tell me they're going to go to McDonald's. So have everything planned ahead of time. One of the really successful, we had a marathon runner patient who was still 40 pounds overweight and didn't feel great, but he was able to run marathons. A single guy, lived alone, he had all these excuses as to why he maybe couldn't eat better. But instead, he started planning his meals ahead of time. He sent us a picture of how he did it. So every Sunday afternoon, he would cook. And he would lay out 21 meals every Sunday in glass lock containers with little snap-on silicone lids. And some of them would put in the freezer, some he'd put in the fridge. But breakfast, lunch, and dinner for the whole week. Lost 40 pounds, felt great. Saved a ton of money because he wasn't eating the junk food anymore. It was kind of fun. We use his picture quite a bit. What are you going to have for snacks? What food am I going to buy to make this all happen? What gear am I going to pack? Am I going to do something nutty like Shelley's weighted vest, which does work? Because remember, whatever you do is going to look nutty to other people. And so if you're not looking kind of like a health nut, you're probably not working very hard at it. Because most of the world is not a health nut. And do I have a plan for sweating 3 times tomorrow? Being short of breath 3 times tomorrow and today? Plan your food out. And we have a whole section in our book on food planning. Just think about the different categories. Fruits, vegetables, grains, beans, raw nuts, proteins, probiotic foods, and sort of sprinkle those through your diet. You don't have to be, if you don't have sauerkraut one day, you're not going to die. You don't have to go crazy. But have a steady, methodical approach to it and realize that it's important. And remember, if you didn't make the food, maybe it's not really food. And once again, I highlight protein powders in this regard. Protein powders are a chemical construct. Do we know if they're good for you? I don't know. They're probably better than starving to death. I'll give you that. But are they good for you? I have a practice partner, so he's also an MD, and he's a weightlifter, and looks like it. And he's about 35. And so he hears people talk about their protein powders, and he say, now, why not eat some meat? And he says, it's just fascinating to watch the responses. They don't know what to say. And I can't figure out where the protein powder business got its market. What made them successful? And I haven't figured that part out yet. But, there's nothing like tuna and meat and eggs and salmon. And remember, whole grains are about 20%, 18 to 20% protein. It's not that hard to get protein if you care to look. And if you ignore the pharmaceutical industry. Certain foods are worth avoiding. Watch out for foods made with flour, especially white flour, which is also called wheat flour. Watch out for white rice. Watch out for sweets. Watch out for refined products of all kinds. And watch out for pretty much all your kitchen oils except for all extra virgin olive oil and maybe coconut oil. The reason I say maybe coconut oil is because we don't really know if it's good for you or not, but I'm betting it is because people have been eating it for thousands of years. Plan exercise. Plan it for more than once a day. Even if it's only 1 minute. Remember, you have no excuse not to do a minute of exercise. You can do jumping jacks right where we are. How long would it take me to get... How long would it take me to break a finger? How long would it take me to get short of breath doing this? Not too long. It's making my nose run even. Which is actually interesting. So when I do pull-ups, I feel my sinuses drain. Someday I'd love to see a study to see if people who exercise have less sinus problems. Because I'm pretty sure that'd be true. So anyway, so I'm doing jumping jacks, right? For a minute. Am I going to be tired at the end of a minute? You bet I am. That's why I'm stopping now. I love my last bullet there. You need to kill your TV. Don't underrate that possibility. That suddenly, if you didn't have a TV, if you didn't have screen entertainment, that suddenly you'd have a whole bunch of time that you had to fill in. You might have to talk to your family about something meaningful. Recently, we were driving to visit some relatives, and it was just a 2 to 3 hour drive. And we had a bunch of my son's friends in the car, and we talked about the idea of talking about ideas. So this concept of, I think it first came from maybe Aristotle. Great minds talk about ideas. Medium minds talk about things. Small minds talk about other people. And we see this in politics a lot. So I hear people talking about politics, and they're talking about personalities. Don't talk about personalities. Talk about policy. Talk about the ideas that matter. what ideas give people better lives? And that applies to politics, it applies to medicine, it applies to all kinds of things. So if you were going to talk about a doctor because he's nuts, which maybe I am, that might be accurate, but the question is, are my ideas good? So concentrate on ideas and how that impacts your life, how it impacts your family's life, and so on. Now, there is more, but we're not going to go into it today. Things like sunlight, outdoor time all by itself probably has some benefits. Sauna or hot bath, and for that matter, cold plunges. Fun. Recently, the friend of ours who's, I guess she's in her 50s, we rode our bikes down, just 3 adults rode our bikes down and threw a Frisbee on the field in the school near us. Simple. It's quite a steep uphill coming back, so we got short of breath and sweaty. The Frisbee was good hand-eye coordination, which is really good for dementia reduction. And we had a good time. It cost us exactly nothing. The Frisbee was already paid for. And so it's worth, and we maintain certain skills. Old people should ride bikes. Old people should throw Frisbees. Old people should play ping pong or pickleball or tennis. There's a huge area there. Having friends. And having friends, you've got to be friendly. There's a proverb about that. And gratitude. So this whole idea of being thankful for what we have. And thankful for what health we have, even if it's not quite where we'd like it to be. And do something to make all this happen. Keep reassessing. Are you doing the things you should? Are you applying what you already know? If you're not applying what you already know, why not? You can see that people who have a victim, every now and then I think about putting a head over our office door, victims / because if you have a sort of a victim mentality, what I'm saying doesn't really work for you. In fact, it's probably offensive. And we see this sometimes. And so that means appreciating the power you have over your health. And it's kind of funny because our patients with advanced cancers often are the best at thinking this way. They say, okay, this is what I've got. What am I going to do? And they often lose the victim mentality. And it's kind of interesting. And our patients who have relatively minor disease, like high blood pressure and overweight, are often have the most of a victim mentality. And I haven't figured out why that difference is. In the cancer world, we call it a gift finding. And our cancer patients are really good at it. It's such an education to those of us who haven't had to go through that.
I was just wondering, how important is brain health with weight loss?
So there's a strong association between central obesity and also upper arm obesity. I'll hate to tell you, flappy arms. What my former partner used to call lunch lady arms. There's a strong association between that and dementia. There's also a strong bidirectional component to depression and anxiety. And by bidirectional, I mean that people who are overweight are more likely to be depressed, and people who are more depressed are more likely to be overweight. And there's not clarity as to what leads to the other, or if it's more complicated, which it probably is. So there is a strong relationship between almost every disease process and excess central body weight. In most cases, there are some exceptions. For example, sumo wrestlers, their body fat, the central body fat is actually distributed quite a bit differently than the rest of us. So I only mention these exceptions because I think people get so locked into a black and white view of the metabolism, and it's really not, we don't know that much. So the stuff I've given you, I'm hoping you see it as broad brushstrokes with lots of sloppiness around the edges. So I don't color well within lines because the body is way more complex than we can understand at this point. We have one more question.
Cooking from scratch, planning your meals, logging your diet, sweating 3 times a day, those all take time, and doing it all every day sounds like I wouldn't be able to do anything else. I'm getting discouraged.
So basically she's saying this is too much work because she's got other things she wants to do with her life. And so let's start with the cooking at home. So most of the time when you cook at home, you can cook in big batches and have a lot of leftovers. So you heat up a lot of stuff. Or you eat really, really simple food. Let me give you a super simple example. You take a thick slice of tomato, you put a piece of cheese on it, you broil it. Maybe 2 thick slices of tomato with cheese on it and broiled it. That's your meal. How long did that take? A big casserole that you would then eat for, I used to, when I was single and a resident at the hospital, you know, you're working a lot. So I would do a big pot once a week of various vegetables, zucchini, corn, potatoes, some proteins, ground meat, some cheese, maybe brown rice or cooked barley or something like that, and I'd just bake all that. And then I'd spoon it out. It was actually very, very tasty. I'm not saying this was miserable at all. It was actually really delicious. But I would eat the same thing for a week. Now, there'd be some other things thrown in there as well. So first of all, leftovers. Secondly, simple food. And we hope that people see the recipes in our cookbook as being designed around being simple. And there's a food planning section. Thirdly, the exercise 3 times a day for 1 minute. Everybody can do that without taking time away from anything else. So we won't touch any slack on that. What else is taking too much time?
Planning meals and keeping a log.
Oh, keeping a log, that's 30 seconds after each meal.
No, I've done it, it's a lot more than that.
Huh. How much time did it take you?
Well, let's see, I was counting calories.
Oh yeah, we say counting calories is a waste of time. It's too hard to do accurately.
So you just write down what and how much?
Yep. Oh no, not even how much, just what. Because then you look at what, and first of all, you get rid of, so when you're making your food log, don't bother counting down how much too much, really. Just write down what you're eating. And then if you're not losing weight that you're trying to lose, if that's what your purpose is, then you just say, oh, well, let's see, most of my calories seem to be coming from this, so I'm going to cut this by a third, the quantity by a third. And then you design, now that measuring the quantity is really complicated. You look at your meal and you take a third of it away. And you leave that for some other meal. So basically you sort of just see simple ways to do everything and say, what is it that's taking too much time and how do I reduce that time? Is that helpful at all? But we live in a pretty simple world, I promise. Yeah.
Do you have any comments about some of the products that we see on the market today to avoid dairy, such as oat milk and some of these other products?
So the question is about synthetic foods. So there's 2 types of milk substitutes. Those that people make at home, because you can make things like oat milk and almond milk at home if you want to spend a lot of time and throw away a lot of good food, because the raw material that's left behind is actually the most nutritional. And so those are all, we consider all those unkindly and uncharitably as chemical constructs. So we don't think any of them have any validity as far as a healthy diet. If you don't tolerate milk, just don't drink milk. If you don't tolerate strawberries, you don't find a strawberry substitute. Because some people break out in rash when they have strawberries or nuts or different things. We don't say, hey, let's find a chemical construct that replaces this. We say, just don't eat it. So our website is greatmed.org. And it's supported by philanthropy and for people like Kadlec. The podcast is Walk, Don't Run to the Doctor, and our book is Good Food, Great Medicine. So I think we're calling it a day. Thank you.
Awesome. Thank you so much, Dr. Hassell. Motivated to make some simple changes?